Okay, good morning, everybody, or should I say good afternoon. First of all, just to let you know, no financial interest in anything that I'm saying.
Sir, just a second. Could you have some quiet in the hall, please?
Yeah. So when we evaluate a patient after surgery, we do a routine post-operative evaluation, which I've actually listed here because it's not common for everybody to do all these things, but we try to do it. So you have to do a proper slit lamp examination. Torchlight will not do. You need to do a Seidels test. You need to check pressure with applanation. And then of course you assess the bleb, and if necessary you can do, even on the first post-op day, you can do a gentle gonioscopy if you need to have some information about what's happening inside. I'll go over a clinical approach to a shallow anterior chamber, and basically one would look to see the IOP next, and if it's a low IOP you would suspect overfiltration or a leak, and with a normal or high IOP you would suspect aqueous misdirection or underfiltration. So here's a sort of flow chart. You have the shallow AC with low IOP. You look at the bleb configuration. You have a flat bleb with or without a leak, and you follow this left-hand side flow. And you have a formed bleb. You have to assume overfiltration. Now we have a flat bleb with a leak, let's say. We need to consider what are the factors which actually control the flow through the trab. The most important is the amount of scleral overlap. When you have created your superficial scleral flap, how much does it overlap the ostium that you have created under the flap? Next would be the tightness and the number of sutures, because that affects what resistance the aqueous has to flow against. And then the thickness of the flap, again that affects the resistance. The actual size of the internal ostium, apart from creating more than the little minimum that you need, doesn't really matter very much. We all excise more than an adequate ostium. Other factors causing hypotony would be the leaks from the conjunctiva, and usually it's a conjunctival edge leak, or it may be from somewhere else on the conjunctiva. If you have undersecretion of the ciliary body, that's ciliary shock, there may be buttonholes, there may be choroidal effusions which may be spontaneous or related to some other pathology, and rare causes would be foreign bodies within the, in the operated site, like a cotton fiber or something, acting as a wick to draw out the aqueous. The careful slit lamp examination will help you. So you need to first of all look and see, is there a bleb present? If there's a bleb present, it's unlikely that you have a very significant conjunctival leak. You do a Seidels test to rule out the leakage. You look at the edges of the scleral flap, which you can usually see through the conjunctiva, and see whether any edge is lifted up or is showing a gap or a gape, and you look for loose and broken sutures. If necessary, you look at the internal ostium, as I said before, and you must always do a dilated pupil indirect ophthalmoscopy, looking for those peripheral choroidals. Now, all fornix-based flaps will leak on massage postoperatively. And when you have a spontaneous edge leak, as is being shown here in the video, you can try and address it with a pad and bandage or a contact lens or something like that. But conjunctival resuturing is usually indicated and can even be done under topical. This is a conjunctival edge leak which has been repaired under topical. And once that's done, you check through a paracentesis to make sure it's not continuing to leak. Now, when you have early overfiltration, there's no conjunctival leak, but there's just too much fluid flowing from under the scleral flap. You need to kind of induce that flow to be a little less, and you can do that by increasing the resistance to the flow. So you can use a torpedo bandage, the so-called pledget of cotton wool, which is placed over the eyelid and presses on the site of the trab. You can use a Simmons shell, which is a device which is shown here, which has a platform which presses over the site of the trab, and you try and compress that. One small clue that I found that is clinically useful is when you have a shallow or almost flat AC like this, if you try and support the bleb area with your thumb through the eyelid and you find that your AC is forming up, you're likely to get some results from your torpedo bandage shell or any other means where you can compress the site of drainage. If you have to intervene, your intervention would take the form of going and trying and revising your trab, and you need to know what's the appropriate timing. If choroidal effusions are already formed and have been there for more than a day or two, it's unlikely you're going to be able to reverse anything without actually draining those effusions. Conservative management will usually not work. You have to intervene surgically if the pupillary collarette is touching the cornea. The choroidal drainage is shown here, where it's a fairly simple procedure. You do need to have, you can't do it under topical, you do need to have a full peribulbar or retrobulbar block. It's important to realize, you can see a lot of fluid flowing out now, that you need to reform the chamber not with air, but with balancol, with a liquid, which is retained there without flowing out. Air will be retained even against pressure and upthrust, whereas a liquid will not be. So here you see that the chamber has been reformed and it's staying formed. This step is important where you try to cauterize the edges of your drainage site so that it stays open post-operatively. It needs to continue to drain in the first few days post-op, and you don't need to worry that it's going to stay permanently open. The sclera heals very fast. Probably in a week or two, it would have closed off. I have had occasion to go back and look at a choroidal drainage site 2 weeks later, and I found that I couldn't even find where the incision had been made. So other surgical interventions would be to just reform with an air bubble or use the cement shell as I mentioned before. But if you have excessive overfiltration, you have to re-explore, and generally the re-exploration would lead on to putting a scleral patch graft. You can try and re-suture, place additional sutures, but usually the situation would be that the overlying sclera, the scleral flap, is now a little too thin and ragged for your sutures to hold well. So you need to cover it up. This is just an outline of what you would do. The indication for intervention and a scleral patch graft is if you have a high chance of infection, or if you have hypotony maculopathy or chronic corneal edema, anything affecting visual acuity. You can try autologous blood injection, you can try laser scarring of the cornea, and several things. Autologous blood injection is successful in about 50% of the time, but it's such an easy procedure, and here you can see I've shown a few slides, that it's worthwhile trying. It's almost non-interventional. Compression sutures can be tried, and they are very effective, but my personal favorite is to do a scleral patch graft. You use donor sclera and you suture the graft to cover the entire original scleral dissection, and the posterior edge is usually left unsutured so that it continues to drain in that direction. And surprisingly, it works, and the glaucoma remains controlled in most of the patients. So I've just got a series of photographs to show you the steps of, you can see the size of the graft, it's fairly large. You must cover the entire area of a scleral dissection. So you suture it down, then you trim and thin the graft, and finally you do put a mattress suture near the limbus, and finally you close the conjunctiva. So in summary, you need to do a careful clinical examination and check the IOP post-operatively. You need to do a Seidl's test, if necessary a gonioscopy, and then you use whatever measures are necessary to address the root of the problem once you've diagnosed what the problem is. Thank you.